Myocardial bridging. Definition: coronary arteries typically course over the epicardial surface of the heart. Occasionally, segments of varying length of artery may travel within the myocardium and reappear on the epicardium more distally in the arterial course. The overlying muscle referred as myocardial bridge and the coronary artery referred as tunneled artery. Incidence: congenital origin 5 to 12%. Mechanism of development of symptoms. Clinical features: in most cases, no hemodynamic significance, but during exercise, increase in flow during systole to meet increasing demands, but diastole is progressively limited by increase in heart rate. Ischemia, MI, arrhythmia, and sudden death occurs. Diagnostic techniques: FFR, IVAS, intracoronary Doppler, MPI, to investigate the perfusion consequences related to bridging. On coronary angiogram, lumen of the tunneled segment of vessels decreased, particularly during systole, but normal caliber during diastole. The figure shows myocardial bridging in various steps. One is epicardial, partial tunneled, thin myocardial bridge, thick myocardial bridge, very thick myocardial bridge. The thick myocardial bridge and very thick myocardial bridge is potentially symptomatic. Myocardial bridging frequently associated with the following conditions: erectile dysfunction, endothelial dysfunction, microvascular dysfunction, spasm, other coronary pathologies. Now, what is the treatment? Conservative treatment includes calcium channel blocker, beta blocker. Surgery includes if persistent symptoms and evidence of ischemia. Now, syntax score. Elaboration: the synergy between PCI with Texas and cardiac surgery. The syntax score is generated by summarizing various qualitative plaque features and serves as objective measures of coronary disease severity. Variables are dominance, right left codominant, number of lesions, segment involved in lesions, total occlusion with subtotal occlusions such as number of segments, age of total occlusions, blunt stores, bridging collaterals, side branches involvement, bifurcation lesion, and angulation, aortoosteal lesion, severe tortuosity, lesion length, heavy calcification, thrombus, diffuse disease with number of segments. Syntax score can easily calculated from online calculators. Now, implementation. Treatment strategy in left main or multivessel diseases. In left main diseases, if score 22 or less than 22, then CABG is class 1 indication. PCI is also class 1 indication. In case of left main with score syntax score 23 to 32, CABG is class 1 indication, PCI is class 2 indication. In left main disease where scored more than 32, CABG is class 1 recommendation, PCI is class 3 recommendation. In case of triple vessel disease, score less than 22 or equal to. CAVG is class 1 recommendation. PCI is also class 1 recommendation. Where syntax score 23 to 32, CAVG is class 1 recommendations, PCI is class 3 recommendations. And in case of syntax score more than 32, CAVG is class 1 recommendation, PCI is class 3 recommendation. This whole criteria is from ESC 2014 guidelines. Now, syntax is the largest prospective randomized multicenter trial included all corners with complex multivessel disease. A total of 1,800 patients from Europe and US were randomized to multivessel PCI with Texas drug-eluting stent or CAVG based on revascularization strategy decision of heart team. Exclusion criteria are acute MI, prior revascularization, need for concomitant cardiac surgery. Syntax trial. Syntax 1 for diagnosis of disease and for revascularization. Syntax 2 for assessment of mortality. Now, hybrid revascularization, the combination of arterial grafting, that is Lima to LAD graft as a part of CAVG combined with PCI to the non-LAD territory. In case of multivessel disease, when technical issue over one of the two techniques, comorbidity, contraindication for sternotomy, previous history of revascularization with limitations to graft conduit and access to PCI. Requirement: heart team hybrid room. Limited coronary artery disease involving the proximal or mid LAD and at least one other non-LAD coronary artery. Example: mid-cap plus PCI, minimally invasive direct coronary artery bypass. Mid-cap means minimally invasive direct coronary artery bypass plus PCI. T-cap plus PCI. T-cap means totally endoscopic coronary artery bypass. Then PCI plus valve surgery. TAVI plus PCI. These are the examples of hybrid revascularization. Now, recommendations from ACC AHA. Current ACC AHA guidelines on coronary revascularization consider hybrid coronary artery revascularization only when PCI of the LAD is considered suboptimal, and therefore it is given a class 2A recommendation. Now, advantage of hybrid revascularization: safe with low mortality rate 0 to 2%, no low morbidity, shorter ICU and hospital stay, superior cosmetic result, faster recovery. Disadvantage of hybrid revascularization: longer operating time, late wound complications, more late pain because of retraction, stent restenosis, and need for repeat revascularization. Now, contrast induced nephropathy. It is the contrast induced nephropathy. It is contrast induced acute kidney injury in which renal injury is caused by IV administration of radio opaque contrast media. Diagnostic criteria. What are the diagnostic criteria? 25% 25% relative increase, 25% relative increase or zero point 0.5 milligram per deciliter, that is 44 micromole per liter, absolute increase of serum creatinine within 72 hours of IV contrast media exposure in absence of other explanations. KDIGO 2012 definition. The international kidney disease. International kidney disease, uh, improving global outcome. KDIGO defined contrast-induced nephropathy as 26 micromole per liter increase of serum creatinine, that is 0.3 milligram per deciliter within 48 hours. Another 1.5 times rise of serum creatinine from baseline, which is known or presumed to have within 1 week, or less than 0.5 ml per kg per hour urine output for more than 6 consecutive hours. That is less than 0.5 ml per kg per hour urine output for more than 6 consecutive hours. Now, what are the risk factors? One is pre-existing renal impairment, anemia, advanced age, that is more than 70 years, dehydration, volume depletion, diabetes mellitus, CCF, hypotension, increased amount of contrast media, use of high osmolality ionic contrast media. Now, proposed mechanism. Contrast media have cytotoxicity and viscosity. With cytotoxicity, damage of endothelial tubular cells. It causes vasoconstriction. It causes reduced medullary perfusions and medullary ischemia and decreased GFR. Another mechanism is contrast media increases viscosity, so reduces medullary perfusions and tubular flow. Also reduces tubular flow, so medullary ischemia and decreased GFR. Now, what are the novel renal biomarkers? Neutrophil gelatinase associated lipocholins, NSAL, NGAL, cystatin C, IL-18, urinary kidney that is KIM1, amount and character of contrast media. Isosmolar or low osmolar contrast media, amount should be less than 350 ml or less than 4 ml per kg. That is less than 350 ml or less than 4 ml per kg. A ratio of volume of contrast media and creatine clearance less than 3.7:1. Calculated amount 5 into weight in kg. 5 into weight in kg divided by serum creatinine in milligram per deciliter. So, the calculated amount of contrast media is equal to 5 in weight in kg divided by serum creatinine level, that is measured in milligram per deciliter. Now, prevention. Risk stratification: low risk, intermediate risk, high risk. In cases of low risk patient, oral rehydration. 1C isoosmolar, low osmolar, and avoid volume depletion. In case of intermediate risk and high risk, with oral rehydration, isosmolar or low osmolar, and avoid volume depletion, we also consider alternate imaging modality, that is MRI, CT without contrast, discontinued nephrotoxic drugs, that is more than 48 hours, discontinued nephrotoxic drugs more than 48 hours before, and metformin 24 hours before. Then prehydration with 0.9% sodium chloride 1 to 1.5 ml per kg per hour, 1 to 1.5 ml per kg per hour for 6 to 12 hours, or for elective patients. 2. Isotonic 0.9% sodium chloride or sodium bicarbonate 1.26% 3 ml per kg for 1 hour before procedure. 3. N-acetylcysteine 600 to 1200 mg orally BD. One day before the procedure. Use of iso-osmolar contrast media, low osmolar contrast media. Minimal amount less than 350 ml or less than 4 ml per kg, that is less than 350 ml or less than 4 ml per kg. Then post hydration 0.9% sodium chloride 1 to 1.5 ml per kg for 12 to 24 hours. Another recommendation 12 hours for elective patients, or 0.9% sodium chloride or sodium bicarbonate 1.26% 1 ml per kg per hour, 1 ml per kg per hour for 6 hours after procedure. Repeat serum creatinine after 48 to 72 hours. Restart nephrotoxic medications or metformin if no contrast-induced nephropathy. If contrast-induced nephropathy, then manage according to AKI guideline. If patient with moderate to severe CKD, prehydration with 200 ml IV fluid bolus, 150 ml if heart disease, then IV furosemide, 0.25 to 0.5 ml per kg bolus. Then start procedure when urine output is more than 300 ml. Novel preventive measures: direct renal protector, ischemic reconditioning. Direct renal protector are remote ischemic reconditioning. Optimization strategies: LV-EDP guided volume expansion, high urine output matched fluid replacement, renal guard, that is high urine output matched fluid replacement, renal guard, contrast media disease and extraction technology. Contrast media, CM delivery and extraction technology. For these with stage 5 CKD, for those with stage 5 CKD, prophylactic hemodialysis is recommended. After contrast exposure if there is already a functioning vessel access for hemodialysis. Thank you.